Does anybody have any questions? Yes.
And this may be sort of for Bobby, but you were talking about knowing triggers for
Yes.
children. So for a child who has had scalding employed as a punishment technique, obviously bath time can be incredibly stressful. So does a foster family get that kind of information from the caseworker that this child has, had scalding employed, so that the parents know that, bath time's going to be traumatic?
Foster parents should have any kind of information that will help them care for the child. Now, I've seen instances in the past working with AFTAG, the family, the Foster Parent Association in Georgia, where foster parents were not given total information about the child, and that's problematic. It causes a really difficult time for the foster parent and for the child. I can't really tell you what that looks like in practice today. That's based on 3-4 years ago.
We hear anecdotally, a lot of parents say we had no idea, and I think that's one of the reasons why that trauma screen is so important, is you can get an idea, you can figure out what the trauma has been and what their behaviors are, so you can begin to figure out what the triggers might be. But I think a lot of parents say to me that they had no idea.
Well, who's responsible for the trauma screening? Is that a DFAC's responsibility, or should that be occurring once the child's in a medical situation?
I know that in our clinic we try to do that with our kids, and then offer a more assessment if there's an indication that they need it. And so we offer that, or we refer if kids are not living in this area and they want to have it done locally, refer them somewhere. I think, and Bobby, correct me if I'm wrong, oh yeah, Becky, sorry.
What I was going to say is the big breakdown in our system has been when we do that assessment, when they enter foster care, what is medically necessary hasn't been done to address the mental health and the trauma piece. Because we know that the cognitive-based behavior therapy is critical. We know the parent-child interactional therapy is critical. The child-parent psychotherapy is critical. But we're not doing that part of the assessment of this being medically necessary for their treatment, for it to go into their treatment plan. This is the EPSDT screenings. We've never been good at that, and we've never addressed the mental health piece effectively in our state.
So is a trauma screening considered a mental health assessment, or is it considered a physical?
It's a behavioral health thing.
It is
Yeah.
behavioral health.
Far too many times what happens is even DFACs don't know yourself. You don't know all that's happened to the child.
That's a great point.
The mood, and when the child comes to us, we learn a lot. It's added as it goes along to the files, but still, you just don't know everything. You've just got this call, you've got the child, you had to remove it. You don't know everything that's, all the traumas that child's been through. And you learn a lot of it as you go along. I mean, I've had children who, like I say, you go take a bath, and they just go berserk. And immediately you begin to figure out there's something that's happened along the way that nobody even knew except the child was having where it came from. So training is very important for foster parents because you gotta learn all this stuff as you go along. You gotta learn to figure it out and basically as it comes.
I think it's a really good point, that even with the most thorough DFACS investigation, there's going to be abuse experiences that are never covered. You just can't, for those chronically abused kids, you just don't know all the things that have happened. It's a good point. Yes?
Yeah, a statement from the back row. When I was at DFACS, Jordan did a lot of training with our staff, and it was invaluable. And I would hope as one of the recommendations coming out of your council is you would look to professionals like her, because the more equipped the DFACS workers are with this type of information, the better work they'll do. And I will always be appreciative of the work you did while we were there.
Well, that's very nice of you. Thank you. The $20 check is in the mail. Thank you.
I think the other thing that's really important to think about in terms of the context of Jordan's work is how this interacts with other agencies. And you think about DECAL, for instance, and keeping, kids do form attachments with their early childhood education providers, and having continuity of care there, even though part of their life may be disrupted, if you can keep that continuity, it provides stability and allows for that continuation of attachment for children. And then also with the DOE, is really gonna be important for these outcomes for these kids.
I think you're right. I think as much stability as you can have with the environment, the better the child's going to do. It's hard enough for them to be separated from their parents, but if they go to a different school or different daycare, that's really hard.
Jordan, can you just update this group, because I know there are people here from all across Georgia. There are only a couple of people like you that have your expertise, I believe, in the whole state. How do you describe what you've done with the telemedicine program to try to provide the kind of expertise you offer into rural parts of Georgia?
Well, we've developed some telemedicine or stations in child advocacy centers and mostly child advocacy centers around the state, so that we can provide distant consultation to, say, a child advocacy center in Stevens County, for example. If they wanted our help, then we would be able to have remote, a live video conferencing with the family and with the medical provider and actually oversee the exam that's being done. I could watch the genital exam. I could help them do the exam. I could interpret it and write a report as if the child had come to Atlanta for our services. I can interview the child, interview the parent, and then watch and guide the exam. And so we've used that in some areas where the medical provider there is sort of just learning how to do the exams, doesn't feel very confident, so they need somebody sort of over their shoulder. We also use it very heavily for people with a little bit more experience, but they still need, every once in a while, they need second opinions about an exam. So they do a sexual abuse exam. They say, I'm not sure what I'm looking at. So they call up and they say, can we do a store and forward second opinion? And we say, yes, well, let's do a video conferencing call tomorrow at 2. And then we get on the conferencing call. We have face-to-face conferencing using WebEx. And then they show me the photos, and I can interpret them with them, talk to them about the case, and then write a report. More and more, we're having law enforcement use that, especially out of Athens, and it's been really helpful. For the first time, out of Douglas County, I actually interviewed a parent of a physical abuse victim, had not been allowed visitation at our hospital for obvious reasons. He was a suspected perpetrator. So I had no way of talking to him, but we used telemedicine to be able to do that. He was sitting in the police station with the officer, and I was just allowed to talk to him and get my history as if he were in the hospital. That's the first time I've done that, and that, I think, is a very effective way of doing things. So I think there are all sorts of ways that you can use telecommunications and video conferencing to spread the skills and the availability of services that otherwise kids would have to drive 2-5 hours to get there, another thing that we're doing is using video conferencing for peer review. So we have 3 groups of medical providers that meet every other month, and we discuss cases. Like I had one yesterday at 4 o'clock, and there were 4 or 5 of us who talk about new cases, talk about new research on sexual abuse. These are the things that just came out. You need to be aware of this the next time you testify. These are the things that are sort of on the frontier of sexual abuse research. Or there's a new test out. How are we going to get that test? We talked about drug-facilitated sexual assault screening yesterday, and one of the providers said, I have a better lab than you guys do. Why don't you use this lab? So it's a great way of sort of bringing up the skills of all of us and making resources better. So, yes?
I have a question. So obviously the implications about this are huge in terms of treatment. Can you talk about, from your perspective, what you think this kind of information could help us do on the prevention side, or where we could go with this to have an impact on what you're saying? If we were to spend money in prevention or put more effort into prevention, is there legitimate, measurable ways that we could see a decrease in these kinds of cases, do you think?
Yes, there are a few evidence-based prevention programs that have, they're tried and true. They do very well, and I think that many of them are involved in early intervention, talking to parents and teaching parents parenting skills and appropriate expectations for development of infants and children, so that they can attach better to the child and less likely to use harsh discipline and physical abuse. There is another program that I think is extremely good, a primary sexual abuse prevention program that's being disseminated across the state called Stewards of Children. And that's a very good sexual abuse prevention program that focuses on adults. And we have a lot of these programs that focus on kids, telling them about private parts and, say no. But this one is different. This one talks to all of us as adults and says, hey, as adults, we need to take responsibility for this, and we need to minimize the situations where children are at risk for sexual abuse. Prevent children from being in one-on-one situations at school or with the Boy Scouts. Know where your child is at all times. Don't let your child spend the night at somebody's house you haven't met the parents. Those kinds of things. And it's very, very structured 2-hour prevention program that I think is extremely good. So I think there are early intervention programs for physical abuse, and then this primary sexual abuse prevention program targeting adults, which are both, I think, very promising.
Bob, home visitation programs that occur from, some of them start prenatally, but some occur within the first 6 months to a year of a child's life, have been shown across the country to be effective at reducing child abuse. Because typically if the abuse doesn't occur within the first year, because it is a learned behavioral pattern by the parent as well, they've learned other mechanisms to deal with the child crying or you know, have appropriate expectations around developmental growth. You'd be amazed at how many kids are abused because they wet their pants. Well, if you're a year and a half old, that's what you do. But parents can have very unrealistic expectations, particularly when they're very young themselves. So home visitation is one that has been proven to be effective at actually reducing not only abuse, but improving parental attachment and a host of other things. So there's a lot of positive that comes with it.
And I hear a lot of positive things about it. I'm curious why we don't see more dollars in our state, why we don't see more dollars in other states, you know, put in these programs if they're effective. And I keep hearing.
You're getting ready to. South Carolina is issuing a pay for success model that will deal with home visitation. I forgot the county that they're going to be starting in, but it's where Greenville, Spartanburg area is. But the governor's there in South Carolina is very interested in this because it also can help, because their program will start prenatally, it also helps with premature and low birth weight children. And those children also tend to be medically fragile, which also leads to greater abuse. So I think you're starting to see nationally an interest in home visitation, and our state to the north is getting ready to do this on a wider scale. And so hopefully from that, you know, we'll be able to learn. I know Florida has had home visitation. It's not for everyone, but it's expensive. That's part of it.
I think-
It's an expensive program.
I think you're right, and I think another thing is that there are these adverse childhood experiences studies. Have you heard of those? Okay, so those are very powerful studies that show a very strong correlation with early abuse and severe physical, emotional, behavioral problems as adults. The more that we get that out to the general public and legislators, the more they realize, I think, that it's fiscally responsible to intervene early to save that money for building more prisons and all the psychiatric programs and the drug rehab programs that are going to be necessary for kids who have been abused. So I think that the more we can get that out there, that there really is a strong correlation between early abuse and long-term fiscally expensive problems, then we're more likely to have legislators say, okay, we do need to invest in the money early on. Instead of building another prison, you build a nurse-family partnership program. Or there are a couple of studies also that look at the long-term cost of child maltreatment. And so throwing out those statistics would be very helpful. You know, it's billions of dollars a year, whatever it is, I can't remember. They do have those studies, and that would be very helpful as well.
Are there other questions for Jordan? Thank you
Sure.
so much